we'll get into something about the invasive fetal therapy. Now, broadly, fetal therapy can be, as Dr. Alpana Madam has already been classifying it, we have to divide it into diagnostic and a therapeutic work. There are two different entities. There are so much recent advances in perinatal medicine. So we have to see now two patients in front of us. One is the fetus, the other is the mother. So the management part for both the mother and the fetus is actually different. And there are so much modalities and diagnostic therapeutic modalities, facilities that are available today. But still, we are treating only about 2% of the fetal abnormalities. The rest of the problems, many are still not very treatable. So in this talk, we'll have the objectives as to gain an overview of the recent developments. What are the recent developments in fetal therapy? I'll be just brushing again the amnio, CVS, chordosynthesis part, and the fetal reduction part again, what Dr. Alpana Madam has already told it. And to understand what is the benefit and risk of different methods of fetal therapy. So you should know when to do what. Now, it doesn't mean we are doing a invasive procedure on the fetus. Doesn't mean that we are heroic and we can treat everything. Now, in certain problems, let's say there is a bladder outlet obstruction for the baby, we can treat only in selected fetuses. Not all fetuses can be treated. So that is also important. And we also need to have a high quality research in fetal medicine as far as we are concerned in fetal radiology and invasive procedures in the future. So these are the two broad classifications. We have the diagnostic part and the therapeutic part. So in the diagnostic fetal interventions, the first thing already we have the chorionic villus sampling, the amniocentesis, and the chordosynthesis. Now, in the first trimester, it is very important for us to assess the basic entities, nasal bone, the tricuspid valve, the CRL. These are all very, very important, including the uterine artery. Before getting into any fetal interventions, you should know basically how to evaluate these fetuses. Now, when you say evaluation, you should evaluate more time. For example, a fetal reduction hardly takes a minute. But before that, you have to do so much evaluation. Which baby are you going to reduce? Why are you going to reduce? If all the babies are normal, which are you going to select? If you are going to select, how are you going to approach? Is there a placenta in between? Is there a hematoma there? Is there a fibroid there? Is there any other fetal cyst or let's say ovarian cyst that is there in the way which could obstruct your needle path? Is the maternal abdomen very soft or it is very large because of the fat? Which needle you're going to use? Whether it's going to be a 10 centimeter needle or a 15 centimeter needle. So all these things has to be evaluated prior to the procedure, including the proper indication has to be taken up and a proper counseling has to be given to the patient and the attender. So that is very important. Now, when you call for the counseling, it is important that you call the patient, call the husband, the whoever is there in between. Otherwise, when you talk, again somebody else will come again and will ask you so many questions. You have to start from beginning again. Call them all and clear all their doubts. Remember, in all the fetal interventions that you do, in the minor fetal interventions, like let's say a diagnostic CVS or an amnio or a fetal reduction, a fetal loss rate of 0.3 to 0.5% is possible. This is nothing related to your procedure. Like you can do the same procedure 100 times, but 101st time you may have a leaking PV or a bleeding PV, or it can be a fetal loss or a termination. Let's say a abortion can happen. So all these things has to be kept in mind. So tell the patient that there is a risk, let's say of 0.3 to 0.5% of losing all the three fetuses while doing reduction, or there can be a problem while doing an amniocentesis. The procedure may look very simple, but you have to go in and explain the patient, the attender and the relatives, the husband very carefully about each and every points. Tell them about more about complications. See, in my practice, generally what I do is I generally put so many negative points in front of them and make sure that after all these negative points, I need to diagnose a case of Down syndrome for your baby. If there is a problem, then the baby will suffer and you will also suffer after delivery. Now take a decision and come back. So this is very important. Now put the ball in the patient court. You cannot take a decision for the patient. You never take the decision for a patient. How much ever good you think, remember this world is very cruel for doctors. How much ever you think good, it is very important that you tell all the negative points, all the positive points, the benefits, let them weigh, let the family weigh, and then come back to you saying, doctor, okay, we are ready for the procedure. That is very, 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 very important. So coming on to the fetal sampling procedures, as you know, there are two major indications. One is to have the karyotyping, the other is infection. Now, when you do a first trimester screening, you have a risk scoring that you'll all be knowing how to diagnose, how to do a risk scoring for the fetus, including the CRL between 45 to 84 mm. You do an NT, you do a nasal bone evaluation, you do a proper beta HCG and PAPA during that period, put it in a software, evaluate it, make sure the risk is high or a low. This is how you do a high risk or a low risk procedure. Now, when you have a high risk case, you put the patient for a karyotyping. Or when the patient gives you a history of previous pregnancy with a fetal abnormality like a Down syndrome or a Turner syndrome or let's say a Edwards syndrome, or the patient baby already has a biochemical abnormality. Now, there is a word that you will have to understand, the word called index case. That's called index baby. Now, when a parent come to you saying, my previous baby had a problem, collect all the reports, see what the report is. That is very important. That's called the index case or the index baby. Now, when you have the index case, let's say the baby has a phenylketonuria abnormality. After delivery, they are found out. Now, the parents want to know, I want to know whether the second baby will also be affected. Now, you'll have to know whether it is a autosomal or a sex-linked related disease. Is it a dominant or a recessive disease? It's all available in Google. No, you need not scratch your head when the reports are available. Just go in, Google it, find, okay, these are the things. And once you start doing it again, and again, over a period of time, all the common abnormalities is just fixed into your mind. You know whether it is an autosomal or a sex-linked, it is a recessive or a dominant disorder, what is the recurrence percentage, everything will come to you automatic. It is just simple mathematics. It's very, very, very easy. Only thing is we are afraid of genetics. Oh, genetics, my God, I don't know. I know about 22 chromosomes and only X chromosomes. No, it is actually easy. It's all mathematics. Now, you have to just go in and dwell into mathematics. Over a period of time, you give a period of time of 6 to 1 month, 6 years, 6 months to 1 year, you will automatically, everything falls into a place. It's like driving a car and everything falls into a place. Okay, this is thing, this is thing. It's very easy actually. So you need to know. So this is called the index case. So index case is very, very important because index case you will have to evaluate and you will have to know what are the previous abnormalities of that baby had. It becomes very easy now when you have a chromosomal abnormality. You can just pick that abnormality, do the analysis. You take the sample of amniotic fluid or a CVS, send it to the lab, tell them the previous baby had this abnormality, find this abnormality. It's simple. You need to understand three different things here. One is the karyotyping. Karyotyping is the word, means you see the entire chromosomal pattern. There are 23 pairs of chromosomes in which 22 are autosomes and one is a sex chromosome which is paired. Everything is paired. Now, this is called a general karyotyping. The other word that you will have to understand is microarray analysis, the FISH or a QFPCR. There are multiple different analysis. What you see in karyotyping is like, okay, in my house, I have so much rooms. That's all. You don't know what is inside the room. Is all the room in place today? Yes. That is called eukaryotypic abnormality. Eukaryotype. Eukaryotype means normal karyotype. So that is the normal karyotyping. So in my house, I have 6 rooms or 5 rooms and the kitchen. Everything is in place today. But what is inside the kitchen? What is inside my crockery cupboard? What is inside that? I do not know. So in that you cannot see by general karyotyping. Are we clear with that? So general karyotyping is what you see is 22 autosomes and you see one sex chromosome. That's all you see. So 46 chromosomes. That's all. Now, when you come to QFPCR, or you call it as the other one is FISH, fluorescent in situ hybridization technique. That is where you see, is there everything is right. That is, you select, okay, this I see only one room. I color that room and I see my pink room is fine. I have one pink room which is fine, but that's they color the chromosomes. 21 chromosome is colored, and 13th chromosome is colored, 18th chromosome is colored. So you see whether there are 2 or 3. So that is called as fluorescent in situ hybridization. You give fluorescent dye to it and you see the glowing chromosomes. That is second. Third, it is called the QFPCR. QFPCR is nothing but polymerase chain reaction. You know that. It is nothing but you actually take the chromosome, multiply it so many times, and see how many times it is recurring. That is what you see. Now, that is called QFPCR, where again, QFPCR in fish, you can get the reports within 2 days, 24 to 48 hours. Karyotyping takes about 2 to 3 weeks. Last thing is which I wanted to say about is microarray analysis. What is microarray is that I go inside my room, that is in the karyotype, I see the chromosomes. In the chromosomes, I go inside the chromosomes and see what is there inside the cupboard of my room. So that is, you have to go in and see for specific areas. So that is called as microarray. Where do you use that? You use when there is a fetal abnormality. Now you have a you are going to do a karyotype for a fetus which shows high risk, and you do the scan, you have a fetal structural abnormality. Now when there is a fetal structural abnormality and you have a high risk for karyotyping where you are going to do, in those cases it is always better to go and do the microarray analysis. So this microarray is where you go inside the chromosomes and then you go and see for certain abnormalities. There can be a small deletions or duplications. Now this deletion duplication does not occur at the gross level. It occurs at the micro level. It goes inside the chromosomes. Again, in which there are areas, for example, for me, I have so many enzymes. In so many enzymes are placed at different positions inside the uh, autosomes, inside the inside my chromosomes, or inside my let's say in 20th chromosome, I have let's say for my tyrosine dehydrogenase enzyme is placed at this level. Now you have to go and see into it. So that requires another different exam. That is called as exome evaluation. So you see an entire house, all the rooms are correct, that is karyotyping. You see only a overall gross numbering of the chromosomes. If you want to see inside the chromosome, you'll have to do a microarray where you have to do it specifically for structural abnormalities. Remember, when you have structural abnormalities, when you are not able to put into a syndromic variant, always we have to go and do a microarray analysis. When you want to see inside for specific enzymatic representation, there is a chromosomal representation, you will have to do a exome sequencing. That's called exome sequencing. So these are the basic investigation. Fish is nothing but coloring it. Now, what are they? Coming back to fetal sampling, you have CVS, you have amnio, chordosynthesis, you have karyotyping, where previous baby with karyotypic abnormality, high risk for biochemical in biochemical investigation, treatable fetal abnormality postnatally, these cases. Suspected infections, you have to do a amniocentesis. Now, when the patient does not want to carry the pregnancy, let's say the patient comes to you and say, no, I don't want to carry the pregnancy, I don't want it, abort the pregnancy. I don't want to do any test or invasive procedure with you. What do you do? See, there is an option where you can abort the fetus and ask the gynecologist to take these samples, or you can go and take the samples from the fetal skin and the placenta, fetal skin from the back or from anywhere, wherever you want, pluck with using the tooth forceps, take it, put it in saline. That's important. Do not use any formalin here, and the baby should not be wiped with sterilium or betadine solutions. So you can pick the skin, you can pick the you can take some tissues from the placenta, put it in saline and send it for analysis. But there is a possibility that there can be a culture failure in about 40 to 50% for these cases. But still, as I told you, the QFPCR will give you a very, very good insight in these cases where the patient does not want to undergo or does not want to spend for CVS amnio or CVS or an amniocentesis. Patient wants to terminate the pregnancy. Still, the patient undergoes a termination. Still, you can take the samples and try to get the maximum information what the abnormality is all about. Again, as I told you, sitting with the patient, consenting, as already Dr. Alpana Madam has shown, that consenting is very, very important. Counseling is absolutely important. Detailed ultrasound examination before the procedure is very important. Right. So this is one example of the CVS. Generally, I use a double needle system sometimes, but in most of the cases, this is not required. You can use a direct single puncture needle. There can you see the only point is the tip of the stillet should not be sharp. It should actually be rounded so that the collection is very quick. It's actually you can do in single passes. You can do a good collection. Needle tipping, again, see, tip of the needle is very, very important, and you have to know where the tip of the needle enters. Now, a simple technique is do not move. If you are a right-handed person and if you are going to use a right hand for the needle, fix the left hand of yours with the probe where do you want to. That's the target. Do not move your left hand. Do not move your, that's the target. Now fix it there. Bring the needle to the subcutaneous tissue. See, the usage of local, again, I generally don't use local, but if the patient is apprehensive, you can use a little bit of local. Nothing harms that. You can use a little bit of local, 2% lignocaine in the subcutaneous tissue. That's just to comfort the patient. That's all, nothing else. So just go in to the subcutaneous tissue, wait. Now adjust the needle in the subcutaneous plane. After entering the myometrium, because myometrium is a very solid tissue, after entering the myometrium, it's very difficult to actually move the needle here and there. Even if you move, there is a possibility the patient may experience pain. You might actually cause a chorioamniotic separation. So if at all any change you want to make to the direction of the needle, do it in the subcutaneous plane. That's a simple trick and tip. You just go into subcutaneous, wait, bring the needle to that. Okay, my left hand is fixed, my needle is here. Fine, adjust the needle here. Do not move the left hand, it should be fixed. Okay, I move it, fine, I got the needle going. It's very simple. Once you start using this technique, the things becomes absolutely simple. So this is how we get the CVS sample. Once CVS sample is done, put it in the petri dish and send it for analysis. Now, in all CVS patients in cases, make sure you send the maternal blood also together to the lab which you are sending it for analysis. Why? Because sometimes there is a possibility called as mosaicism. What is mosaicism? See, mosaicism is nothing but you have two different cell lines in a same fetus. There can be one cell line which is normal, the other cell line which is abnormal. That's called mosaicism. Now, when they see this mosaicism, they want to know whether this abnormality or a normality has come from the mother or not. Sometimes blood contamination do occur at the micro level. So when they analyze the mother's blood, they will know which is from where, if there is a contamination. If there is no contamination, that's absolutely fine. It is a mosaic abnormality, it can be seen. Another important point is that, again, the risk of fetal loss are about 1 to 2% yes, the day before, but or long time before. Now it's about 0.3 to 0.5%. It's very important. Again, one important thing, again, I'm telling you, is when you have to know the blood group of the mother. Why? Because when the mother is a negative group, your needle prick can cause blood transfer and can lead to RH incompatibilities earlier, much earlier. So in those cases, if the mother is negative group, make sure after your procedures, after your interventional procedures, any fetal intervention procedures, make sure you give the anti-D injection intramuscularly to all these patients. We generally give 250 micron units of anti-D for all the mothers who have negative group. Amniocentesis, again, see, just I'm telling you one trick, again, needle tip, adjust it at the subcutaneous level. When you go into the myometrium, make sure you enter into the amniotic cavity within a fraction of a second. Do not give too much pressure, or let's say the pressure should not be too much so that there is indentation of the myometrium. See, the more the indentation means your pressure is blunt and the more and more time you are going to give the blunt pressure into it, or the more pressure or the myometrium, there is a chance the amnion is going to buckle. If the amnion buckles and separate, you cannot, it's very, very difficult to puncture the amniotic membrane and to get into the amniotic cavity. So make sure once you go, adjust the needle. So fix the left hand, adjust the needle, go into the subcutaneous plane, see the needle tip, just give a quick jab into the amniotic. Make sure that you tell the mother there's going to be a small pain. Just wait. Don't wince. Just wait. I'm just putting. That's all. You have to enter into the amniotic cavity. Then start aspirating. So that is the basic technique that you will have to follow. Fetal blood sampling, again, it's not much done nowadays because of the amniotic development and so much techniques with amniotic fluid evaluation and all those stuffs. Generally, where we do fetal blood sampling is before fetal blood transfusions. We puncture the umbilical vein and then take a sample of blood and send it for analysis to see what is the hematocrit, what is the hemoglobin of the fetus is all about. So you could see here again, I fixed the needle. I'm not changing the position. You could see here, you could see the needle tip getting into the umbilical vein. So this is through and through the placenta. Again, nothing happens when you do a single puncture through the placenta, and you go in, and once you puncture the umbilical vein, there is a free flow of blood through the needle. If you are going to put it in the artery, there is going to be a pulse style flow of blood into it. Again, umbilical vein has a bright red because it is oxygenated. So umbilical vein is a slow flow exit through the needle, and it has a bright red color. Make sure that it is a oxygenated blood. Send it for analysis. So what happens? Suppose if there is a cord hematoma, or suddenly I prick the artery. Oh, I have pricked the artery. What will happen? See, you're going to prick it with about 22 or 21 gauge or a 20 gauge needle. Nothing happens. Don't worry, nothing happens. There can be a mild hematoma or a bradycardia which settles on its own. Again, as for any other procedures, it's about the fetal loss rate is about 0.3 to 0.5%. See, doing all these procedures, the important thing is that the confidence you should have. Once you have confidence in yourself, the patient develops confidence in you. The way you talk, automatically they stick with you, and your referring physician also just sticks with you. So this is what I want to re-emphasize. The reason why I told about the karyotype fish early, just to revise all this again. See, this is a karyotype. What I see 23 rooms here. Does all the 23 rooms have 2 doors? Yes, all the 23 rooms is fine. Every room has 2 doors. Everything is fine. Now this is an absolute normal karyotype. So what do I see in fish? I color the 21 chromosome. Again, I could see the third abnormal 21 chromosome here. So that is the trisomy example. This is what the PCR does. PCR multiplies your DNA and gives you multiple copies so that you can see is there any abnormalities. So again, this is an example of how this microarray is done. See, again, you could see here, there is, for example, if there is a recurrent cardiac abnormality, there can be a 22q11.2 deletion. See, it means in the 22nd chromosome, in the 11th position, that is in the 22nd room of my house, in the cupboard, that is the 11th one, in the second rack, that's a short arm, that is a 22, there is a short arm, in that cupboard, in the position 2, there is a deletion. So this is the so much detail that you can get with microarray analysis. So in the 22nd chromosome, short arm, the 11th position, the subposition 2, there is a deletion. This is what this entire thing means. In the room, in the cupboard, if there are 2 cupboards, in the small cupboard, in the 11th rack, my second t-shirt is missing. So that is what the example is all about. So this is what the entire, so 22q11.2 deletion. This is nothing but max. You just have to be with it for some time. It comes to you automatically. So this is not used nowadays. This is backs on beats. This is not used much. So this is a very rare example of, sorry, this video is not running. So it's a very rare example of fetal muscle biopsy. This was a case where there was a previous history of Duchenne muscular dystrophy. There was a muscular dystrophy, but the patient did not have any records. Once the baby died, they burnt all the reports. They didn't have any copy of it. They came in, and I waited till 16 weeks, 15, 16 weeks to see what baby is it exactly. Initially, I knew it was a male. I didn't tell the patient though, but PCPNTT doesn't allow. But see, the PCPNTT does allow you to express the sexuality of the fetus in cases of few conditions. When there is a sex chromosomal abnormality, number one, when there is a sexual organ abnormality, number two, and in cases of Duchenne muscular dystrophy, you can still tell the patient. But we didn't tell the patient here. We evaluated. It was a male baby. It was a female baby. We would not have done any procedure. It was a male baby, so we had to go and do a muscle biopsy. We took a punch of tissue from the thigh of the baby. These are the basic fetal interventions. Now, rarely we do skin biopsies using fetoscope. Skin biopsies is generally used when there is, we did a case where there was a recurrent epidermolysis bullosa of the fetus. So we had to go and do the biopsy to make sure that there is no abnormality. Coming on to fetal therapies on a broad, it can be classified into medical management and interventional management. Now, there can be so many radiologists who have been asking, why should I know the medical management? Yes, because you are diagnosing it, and many of the treating physicians doesn't know the medical management can be given to a fetus. That is, through the mother, a treatment can be given without going into the fetus. You can give the treatment to the mother so that you can treat certain fetal conditions. You have to note, and there are extensive interventional management which is available. Now, this is an example of a baby with fetal goiter. There are two different babies. These are fetal goiters. So, when the mother is having a hyperthyroidism and put on PTU, thyroidosil, so these can actually lead to goiter in fetuses, because this propylthyroidsil generally crosses the placenta and can cause severe hypothyroidism in the fetus too. The normal thyroid status can be reduced. In the fetus, unlike adult, hypothyroidism is expressed by enlargement of the thyroid gland. See, in adults, you can have so much hypothyroidisms, you would have seen, where thyroid may be normal sized, or it can have a mild abnormality, or it can be a chronic inflammatory pathology or Hashimoto's thyroiditis. But in fetus, in all cases, the thyroid gland enlarges. Remember, if there is a hypothyroid, the thyroid gland enlarges. So initially what they did was they went and took the sample from the amniotic fluid, assessed the thyroid level. Now that was absolutely non-reliable. They tried putting in needle into the umbilical vein, and now in all this, the important point to know is hypothyroidism in the fetus is always seen as enlargement in the thyroid gland. So if the mother is having any thyroid antibodies, gets a history, if there is going to be any other abnormality of the mother related to the thyroid, the baby, if the mother is a hyperthyroid, put on antithyroid drugs, or if the mother has a thyroid antibody positive for hypothyroidism, make sure you look at the thyroid gland of the fetus very carefully in all these cases. Again, different cases are there. Now, there are cases where the thyroid enlargement may be very large. In those cases, we put in a needle and then we give a injectable thyroxins into, there are water soluble thyroxins which is available, and you can just put it in the amniotic cavity so that the fetus swallows it. You need not puncture or you need not give intramuscular injection to the fetus. Just put it in the amniotic cavity so that the fetus swallows the thyroxin, that is the thyroid, and then they actually get the normal thyroid. So the important point is to note is, if the mother cannot be treated, and the mother is a severe hyperthyroid, has to be put on drug, where you cannot withdraw the drug from the mother. You can do a transplacental or an intra-amniotic thyroxine infusion so that the mother, the fetus swallows it and then gets it right. So follow it up after a week. How do I monitor? How can I monitor? Now I have given a thyroxine. How can I monitor? Important point is the thyroid gland swelling decreases in the fetus. That is a dramatic response. Why should I do all these things? Can't I leave the fetus like this? The problem is, if the baby has a hypothyroid setting for a longer time, close to the pregnancy delivery, that's about after 30 to 38 weeks, there is an important thing developing in the brain. That is, the neuronal structural maturation starts to occur. So the gyration and sulcation in the fetus occurs till about 26 to 28 weeks. After that, the neuronal maturation starts to occur. All the migration has completed. Now the maturation. So after the migration is complete, the maturation starts. So in the maturation means the perineural fluid is actually replaced, and it's actually replaced, and the neuronal structures become mature. For this, thyroid is absolutely essential. Otherwise, you're going to deliver a cretin child. Remember that. So that is very, very, very important. Next comes to fetal heart block. Generally, we see so much bradycardia in a fetus. So what is bradycardia? Again, that's a question. So less than 100. Just keep it less than 100. Simple. Usually 110. If it is less than 100, it is definite bradycardia. In all the cases with fetal bradycardia, what are the things should I evaluate? Now, there is a case referred to you as a case of fetal bradycardia. Now, what should I do? Number one, confirm it is a bradycardia. The baby is moving normally. Baby is able to flex and extend. Still after the movement, the heart rate is not picking up. So how long should I measure? Now, you do a proper evaluation for at least 15 to 20 minutes. So in that 15 minutes, the heart rate should not have crossed 110. Number one. Number two, once you have confirmed that it is okay, this is a case of heart block. This is a case of heart block. Where have you measured? Have you measured the artery, the atrium or the venous level, ventricular level? Now put a marker or put your cursor across the atrium and the ventricle and evaluate the heart rate again. If the heart rate of the atrium and the ventricle are same, less than 100, complete heart block. Straightforward diagnosis. If the heart rate of atrium and the ventricle are different, see what is the degree of block. Number two. Number three, look at the valves. Is it thickened? Look at the walls of the heart. Are they echogenic and thickened? These are the steps. Confirm it's a heart block. Do the atrium and ventricular levels. Look for the valves. Look for the walls. Now put the cursor in the mitral and the tricuspid level to see if there is any regurgitation. Number four. If there is a regurgitation, is there any dilatation of the atrium level? So these are the 5 important things that you have to see when you have a cases of heart block. Okay? 5 important points. Now, why should I look at thickening of the valves or thickening of the walls of the heart? So in thickening of the heart or echogenic walls or echogenic valves, the most common cause is a maternal lupus syndrome. SLE. Maternal SLE. Now many of the cases of maternal SLEs are undiagnosed. Remember, they are undiagnosed. They come later in their life for a renal failure where they are picked up, or they can come for a chest condition where they are picked up. But maternity is again another condition which can be lead to pick up these conditions. So if that is the case, there can be a neonatal heart block and a neonatal lupus. These patients extremely benefited, both the mother and the fetus extremely benefited just by using digoxin for the fetus and by using steroids on the mother. In 1 week, you'll just see magic. Everything turns back. So if there is going to be, again, there's a lot of talk on chloroquine due to COVID, but if there is a heart block, hydroxychloroquine, if the the mother has skin rashes, pains and fatigues, this can be used. And hydroxychloroquine is very safe in pregnancy. And hydroxychloroquine can prevent congenital heart block. Now, you know the mother is SLE, then put the mother on hydroxychloroquine and steroid much earlier, so that the baby does not develop any complication, there is no maternal complication. Now, you pick up the heart block, then what do I do is to put the patient simple on dexamethasone until about 32 to 34 weeks. It's as simple as that. Whatever the degree of heart blocks is, dexamethasone helps wonders. How do I give dexamethasone? Do I have to put it into the fetus? No. You have to allow the mother to take it. The mother takes it, it is enough. The steroids crosses the placental barrier and goes into the fetus. Response absolutely very, very good. You need to follow it up every week. So that's the important. You need to follow it up every week. Now, there is another thing. I told you about 5 points which you have to see in congenital heart blocks. The final one which you have to see is the baby is with high drops. This is number 6. Any high drops baby should be evaluated for a congenital heart block or a SLE. Remember that. High drops baby, one of the important cause of high drops baby is a maternal neonatal, or sorry, a maternal SLE. So this is very important. The 6th point is to look for is the high drops. Now, if there is a high drops, then dexamethasone 4 milligram has to be given for 6 weeks continuously, BD, and then taper it slowly. You could see here the heart rate is about 670 here. After putting dexamethasone daily is absolutely high. Supraventricular tachycardia. Now, this is another condition opposite to heart block, where you see fast ventricles, more than 180 beats per minute. Now, I think I've used the word digoxin in the fetal heart block. I'm extremely sorry for that. They use only steroids and hydroxychloroquine. So dexamethasone and hydroxychloroquine there. Use in supraventricular tachycardia, where the heart rate is very, very high, you have to use that. See, here is a case where you have a very high heart rate, it's about 198, and after giving digoxin 1 week, absolutely it has brought back to normal. Now, the problem with supraventricular tachycardia is once the heart beats very fast, so that can lead to improper ejection fraction, number 1. So that improper ejection fraction can cause fetal hypoxic changes even much earlier, so that can lead to brain damage, number 2. Number 3, heart can fail much earlier. So if you have caught it earlier, treat this with digoxin. Digoxin, how do I give? Oral. Maternal oral digoxin is enough. So digoxin is given for 5 days, 2 weeks of 2 days of gap. So in a week you give digoxin 5 days for the mother, 2 days mother has to take a break, 5 days, 2 days break, in that way. So in all these cases, you should ask the mother to undergo electrolyte evaluation much before the starting on digoxin, because digoxin, as you all know, can cause hyperkalemia, can lead to abnormality for the mother. So you should not put the mother at risk. So treating the fetus, you shouldn't put the mother at risk. So that is important to evaluate the maternal electrolytes. It's important. Again, so this is how you see, you use digoxin in cases of fetal supraventricular tachycardia where there is no fetal high drops. Next comes the intrauterine transfusions. Now, the intrauterine transfusion is done for fetal anemia, and it was started much earlier in 1963, but by Lilly, but it was tried by Hobbins in 1974. But actually, large studies started coming after 1980s. So, why does fetal high drops occur or fetal anemia occur? So there are two different problems here. So one is there are two different problems. In the adults, the anemia occurs because there is destruction of the RBC. That is, RBCs either are not produced or being consumed, and there can be a problem. So that is different. That is called anemia. In fetus, it is because of the direct destruction. It's about the direct destruction of the RBCs. Why the direct disruption occurs? Because mother is a Rh negative. Mother is Rh negative. Previously has given birth to a Rh positive baby. Now comes to the second pregnancy, because in the first pregnancy the mother is not sensitized. After the delivery, the mother is immune. That is, the mother marrow is actually sensitized for the Rh positive blood. So when the second baby is about Rh positive, there is a fetal-maternal transfer of blood. So the mother's immune system or the antibody system responds much earlier. So that goes and destroys the RBCs. So the RBCs destruction takes place. That leads to anemia, jaundice, because the hemoglobin is broken down into methemoglobin and carboxyhemoglobin. That's broken down, and that leads to increase in the bilirubin level. That is excreted in the urine, and the baby also is jaundiced even inside the mother's womb. So this was initially tried. The Lilly, what he did was, he went and took samples of the amniotic fluid and then assessed the amount of bilirubin in the fetal amniotic cavity, which the fetus excretes by urine. This was not good, and this didn't turn out well. So nowadays, what we do is we do only a non-invasive procedure, that is using a arterial flow velocities, that is middle cerebral arterial flow velocities. So this is one area where you need to correct your angle while doing a Doppler. Remember, there are so many things. You do umbilical artery, you do MCF or other things, you do the ductus venosus. You need not do the correction. So there are two places where you have to do angle correction in fetal radiology. One is while doing the uterine artery Dopplers. Number two, while doing the MCA Dopplers for picking up fetal anemia. So why does this occurs? Because see, once there is a breaking down of blood, see the blood goes in for breakdown. RBC is broken down, the platelets are there here and there, but RBCs are broken down. The RBCs, they form the crux for the viscosity of the blood. The RBCs are the crux for the viscosity of the blood. Now once they are destroyed, the blood becomes thin. The baby becomes anemic. The blood becomes thin. So what happens? The brain of the fetus senses that the blood is coming okay, large amount of blood is there, it is thin, but I'm not getting enough oxygen. Why? Because the hemoglobin part has actually broken down, and the oxygen binding capacity of the fetus also gets reduced. So the fetus says, fine, I'm getting blood, but I'm not having enough of oxygen. So what should I do? It tries to contract the blood vessel to get more of arterial supply. That is, the peak systolic velocity increases. The baby tries to increase the peak systolic velocity of the middle cerebral artery in order to get it senses in that way. That's all. It senses that the blood is too thin, so I have to contract my vessels to get more amount of blood to get good amount of oxygen. That's what the baby's immune system thinks. So the PSV increases in cases of fetal anemia, whereas in cases of hypoxia, where you do in the third trimester Doppler, you generally see a increase in the diastolic velocity. Remember, so you see the diastolic velocity increase in ischemia, whereas you see the systolic velocity increases in the cases of fetal anemia. Now, what is the target? Multiples of median. What is multiples of median? See, it is nothing but in a normal fetus, what is the normal velocity in that particular week? So you just have to take this chart, put your, let's say you see 27 weeks and you say 48, put it, it's about 1.3 MOM. Now it does not cross. So anything more than 1.5 multiples of median has to be intervened and treated. So what do I do? Again, initial evaluation. It's a complete hydropsia, pleural effusion, ascites, diffuse body wall edema is there. So when do you do? One, I told you about the cardiocentesis. Now put in a needle into the umbilical vein, take a drop of blood, send it for analysis immediately in the next table. Use a heparinized needle so that it doesn't clot. Take it, send it to analysis. Fine, you have sent it to analysis. In the next room, make sure the hematocrit is less than 30, and then you have decided I'm going to do a transfusion. What do you transfuse? You transfuse an O negative blood. It should be washed and irradiated up to 30 gray, and this is just to kill any other organism. That's all. Hematocrit of the sample should be more than 80%, and it should be acceptable. So now you know the hematocrit of the fetal blood, which you have taken immediately. You know the hematocrit of the blood which you are going to transfuse. Now with that, you just have to put it into this particular formula. You can take a screenshot of this, of anything you want, but you see the volume of fetoplacental into hematocrit. What is the hematocrit you want to achieve? What is the hematocrit of the fetal? Let's say the initial fetal hematocrit is about 30 and you want to achieve at about 40, or let's say 80 minus 40, and what is the transfused blood hematocrit, which is 80%. So what is the fetoplacental volume? It is calculated by Mendelian formula, that is 1.046 into fetal weight into 0.14. So this is one particular formula. This is the widely used formula. Now You can take a screenshot it and use it, or you can go to a website called perinatology.com, where you can just put all the values, put the fetal weight, put the hematocrit final you want, initial you want, transfused blood you want, put it, and you will know how much of blood you need to transfuse. Another simple method is fetal weight into 0.02. But see, the problem is for every 0.02 multiplication, you will increase the hematocrit by 10. For example, if you want to increase the hematocrit by, let's say, 80, you will have to do it with 0.8. So that is what this means. But this is the most acceptable and easily available formula. So you could see here complete needle. You see the entire needle got into the umbilical vein, transfused, and the blood is being transfused slowly. So generally what we do is we generally take a look at the heart rate. Is there any bradycardia? If there's going to be a bradycardia, generally we stop the procedure, wait for some time, and then redo the transfusion. So it has to be done by single hand injection. You can do. You can use a 3-way, and then you can start. See, I'm checking the heart rate. It's fine. Again, going back to the needle, and then you can see where the needle is and how the transfusion is going on. Is there any bradycardia? I'm just checking in and going in for again the next transfusion there. Intraperitoneal transfusion is nothing but when it's rarely used nowadays, where you just go into puncture the abdominal cavity of the fetus and then transfuse blood. Risk is same as the previous anything. Again, the shunts. Coming on to the shunts, shunts are like you put a small tube. When there is a pleural effusion, you can put a small tube, one end of the pleural cavity, one end of the amniotic cavity. When you have a vesica-amniotic shunting, where you have the bladder outlet obstruction, putting one end of the tube into the bladder and the other end into the amniotic cavity. So it is important to know what abnormality you have. So it should be a posterior urethral valve, number one. It should not be completely an hydroamniotic sac. It should be a male baby, remember that, because in the female babies you will have complete urethral atresia and there can be a microcolon syndrome associated, which can have a very bad prognosis postnatally. So you need to do that. So vesica-amniotic shunt is nothing but to release the pressure. See why? Because when there is a bladder outlet obstruction, the bladder is distended, which can lead to dilated system. That is bilateral hydrohydronephrosis can be there, which can lead to constant compression on the renal parenchyma, which can lead to renal failure in these babies. So you try to prevent the renal failure by actually diverting the blood supply. So pre-procedurally, it is very important to analyze the sodium, calcium, and the beta microglobulin levels. At least the calcium level is very important. Now, calcium level should not be very high. See, calcium level being very high, it means the fetus kidney has lost the ability to concentrate urine. That is the first sign. In adults also, you could see the early renal failure patients, they pass more urine. They are polyuric. That's because the concentrating ability of the kidney is what is first lost. So when the baby's fetal urine has more calcium, it means the baby is unable to concentrate the urine using his or her kidneys. So this is the three important instruments we have. There's the trocar, the guide or the pusher, you have the wire, and you have the needle. So you could see the procedure here. So this is what we are evaluating. So we have seen the bladder is distended. There is no much oligo. The kidneys are normal. The calcium levels are normal. So once we are confirmed with that, what we do is we go and start puncturing into it. So sometimes the baby moves very fast. In those cases, you can just put, see, you could see the needle there. Yeah, I'm just seeing the needle, just puncturing it, avoiding the umbilical structures going into the bladder. That's all. Sometimes the baby moves very fast, so in those cases, generally what we do is you can puncture the fetal thigh with a 22 gauge LP needle and then give a small drop of vecuranium or a pancuranium so that the baby is paralyzed during the procedure. So once this is done, we are passing the, once this is done, we know, yes, we are inside. Now the wire is passed, the catheter is placed inside. Sorry, the video has changed, okay. So once this is put into the needle, the wire is passed and then the needle is checked in position. You could see that's the catheter. One end of the catheter here, the other end goes into the amniotic cavity. This is the posting. You can see the bladder, you can see the catheter on both sides. So there is a survival rate about 40%, and end-stage renal disease can be prevented in about 40%. So it is important to know this particular final line. So as I told you, you should know when not to do procedures. When there is severe oligohydramnios, it means shunting will not prevent the renal damage. You can do shunting. It's very easy, straightforward procedure, but after delivery, the baby's renal function is not going to improve. Amnio infusion is generally done if you have oligoamnios where you want to see structural abnormalities of the fetus. Only for those conditions you use only a warm ringer lactate is used. That's all. Amnio reduction, when there is a severe hydramnios, if they AFI more than 35, and the patient comes to you at about 34 weeks, this maternal respiratory distress is there, but you want to give time for the baby to grow still more in the third trimester. You put in a needle and then aspirate so that till what time should I aspirate? Now, the suction apparatus with a low suction thing you can use, where you have to aspirate or you have to take out the fluid so that the maximum dimension of the single vertical pocket is 6. So till then you can do the reduction procedures. So after this reduction procedure, it means that you are suddenly decompressing the distended amniotic cavity. So in those cases, we always use a calcium channel blocker for the patient. We use an NTG patch over the abdomen, or you can use a calcium channel blocker orally to the drugs. So multiple pregnancies, again, I'm not going into detail because already Dr. Alpana Madam has gone into it. So again, selection of the fetus is important. Seeing the needle tip is important. Going into the heart is important. You just take a drop of blood and put in 1 drop of concentrated HCl. Do not dilute it. Just put in a drop. Nothing happens. The baby just stops there. If you are unable to puncture it into the heart, go into the thoracic cavity, you'll have to put the KCl in a good, let's say 1 ml or 1.1 ml or 1.5 ml, and slowly wait till the heart stops. So again, there is a question: what happens if the patient KCl just goes into the amniotic cavity? Should I go and aspirate again? Nothing happens. Don't worry. The cross-placental transmission or a cross-amniotic membranic transmission is absolutely nil, so you need not worry about it. This is another case where you have to know which baby you're going to reduce. Now, knowing the baby reduction is very important. See, you could see here, that's a heart, and after the procedure, you'll see absolutely no heart rate in this fetus. So, again, the steps are very important. This is a baby with hydrops, which has been reduced. So, the steps are very important. You should know where to enter, how to enter, and how to track these needles. This is very important. After every procedure, remember, after every of this procedure or every after reduction, make sure that you see the patient after 1 hour. Give the patient a comfortable room, ask her to lie down. After the procedure, generally we give a sustain, micronized progesterone, 400 microgram transvaginally. Keep it, allow the mother to rest for at least half an hour to 45 minutes. Ask her not to move. After that, call back again, do the ultrasound, make sure the heart of the baby you have reduced has stopped, and then send the mother away. Sometimes you might inject into the cavity, there can be a re-pickup. The heart can re-pick up. The other procedure is intrauterine valvotomy. This is only for when there is a valvular stenosis at the mitral level. We have done one case about 2.5 years ago. See here, this is a case where there was dilated ventricle and there was a severe aortic stenosis. The rest of the heart was absolutely normal and there was no cardiomyopathy there. Normal mitral valve, but it was very normal mitral valve, and there was a completely narrowed aortic stenosis. So we took, this video is not running, I'm sorry for that. So this needle, we took it into the fetal heart. This baby was paralyzed by using vicurinium. Get into the fetal heart substernally. So again, see what happens if I puncture the fetal heart once, nothing happens. Don't worry. Single puncture, nothing happens. So go into there, put a wire across the, this is using a simple cardiac catheter. That is, we used 0.18 wire, go into the cavity and then do a small balloon using a 3 millimeter balloon. We just dilate the scope. Coming on to the fetoscopy, fetoscopy again was there long back, and after a lot of ethical issues, it got stopped again. After 1990s, it started to pick up its own thing, and after 2000, predominantly many of the things are used. So the most common indication for fetoscopy is a twin-to-twin transfusion syndrome. So what is twin-to-twin transfusion syndrome? So twin-to-twin transfusion syndrome is where you have a single placenta, and you have two babies in the same placenta where there is a cross circulation. So that is very important. So you have cross circulation where one of the fetus grows larger, more amniotic fluid, one is smaller, less amniotic fluid. Now, this oligo poly sequence in a case of monochorionic twinning is very, very important to diagnose it's a TTS. When there is a normal liker in one of the fetus, reduced liker in the other fetus, it is not TTTS. It is selective growth restriction. Remember that. Selective growth restriction cannot be treated with scopy or a laser ablation, whereas twin-to-twin transfusion can be treated with a laser ablation. So excess blood, larger baby, polycythemia, more amniotic fluid. Smaller baby, anemia, absent bladder, less amniotic fluid. Now this is very, very important. So when do I say polyhydramnios in twins? So if you want to say poly or in a twin baby, one of the twin baby, single vertical pocket should be more than 8. A single vertical pocket should be more than 8. If you want to say oligo, a single vertical pocket should be less than 2. That's many of the times this membrane is very difficult to pick up. It is just opposed to the fetus. It's just opposed to the fetus. So sometimes it may be very difficult to pick up. So pre-procedural USG is completely important, where you have to say the whether it is an arterio-arterial, veno-venous, or a arterio-venous communication. All these things can happen. So this is my setup. What we use is a laser machine. This is a laser fiber here, and this is how we do the procedure. So how do we take the puncture? You could see here. So that's the puncture we take. We go into the larger, there is the amniotic cavity which has more fluid in the most perpendicular pattern to the placenta. Now, why? Because this is called the zone. That there is called as the zone of arc, where you have to go and puncture exactly perpendicular to the placenta. So generally select the babies where there is a posterior placenta, which is easy. If you want to have an anterior placenta, then you need to have a curved scope. Whereas here you can have a straight scope like this. What you have, go puncture it here and go inside, so that you will be able to see the anastomotic vessels. Now the anastomotic vessels all happen in one equator. That's called the anastomotic equator. When you go inside, I'll show you that in the video. So once we puncture it, this is how the fetoscopy looks. So you could see here the baby's hand here. So that's the cord here in this thing, and you could see that's the flakes because the amniotic puncture. You could see here these are the nails of the fetuses, and these are the membranes. These are vessels in the dividing membranes of the fetuses. You could see here. So this is the fetal leg. You could see the nails very nicely. This baby was sitting exactly on the placenta, so I had to wait for the baby to move. I cannot just move. Sometimes the baby even catches it. You could see the nail much closer. So I had to wait till the baby moves away from the placenta. This happened after the puncture. So the baby showed all the limbs. You could see here the hand of the baby here, the nails of the baby folded here. That's the, yeah, we are going to see the face of the baby, right? So now this is important. Now this is, again, I'm stopping the video here. This is the vessel. So now you know the umbilical artery is dark red, the umbilical vein is bright red, right? In the placenta, remember, all the vessels travel together. The vein and the arteries, they travel together. These abnormal vessels travel alone. These are loners. These mean that these are communications between the two fetuses. So that's how we say, okay, this is an abnormal vessel in this fetus. So what do? We take a laser and then we go and burn the particular vessel. This is non-touch. This tip is very sharp. If you touch the vessel, that's all. You lose both the fetuses. There is a baby loss. So that's the ablation. This is photocoagulation, which has happened. See, again, another part, I'm just coagulating for the safety part of it. That's all. I want to coagulate it for more without touching the umbilical cord. So it's a non-touch technique. We keep it at about 0.5 to 1 centimeter away, and we completely had coagulated the entire vessel. So once you enter, see, the entry is all by ultrasound guidance. When you enter into the ultrasound guidance, then you have to take charges by driving a car, putting a laparoscopic instrument into it, and then it just needs some practice to get it. So after reduction, we generally drain the fluid, as I told you, because there is a polyhydramnios. We drain it so that the maximum vertical pocket in the polyhydramniotic sac goes to 6. And this is the post-evaluation Doppler, which is absolutely fine. So this can happen if you have a stage 1 or a stage 2 or a stage 3 early TTTS. But if the stage 3 late or a 4th stage TTTS has already happened, or this late stage 3, then possibly you cannot save one of the babies. You have to sacrifice one of the babies. So what do? We can go and occlude the cord. We cannot put KCL in a monochorionic pregnancy. Remember that if you put KCL inside the one of the fetus in a monochorionic pregnancy, the KCL can transfer and go into the other fetus and can kill the other fetus also. Remember that. So there is no role for KCL in a case of monochorionic twinning. So it's always important to evaluate the fetuses before doing any invasive procedures. Be careful about it. Once you have done the damage, you cannot reverse it. So this is a case where you have to reduce one of the fetus. So this was an abnormal small fetus. So we just put in a needle and then transfused some normal ringer lactate into it so that you get enough space for us to work on. So using this is done on a complete ultrasound guidance. So this is the trocar which we introduced into the sac. So once the sac is introduced, you could see here that using the bipolar cautery, there is a special bipolar cautery which we catch the umbilical cord. So once the umbilical cord is caught, we give the current energy and then it goes in for burning. So this is what happens. There are bright signals that happen. So after that, you could see here the bright signal that's happening, and after that there is a complete cessation of blood flow. You have to occlude the cord because if one of the baby expires inside, you do not want the toxic substances of this baby to transfer across the umbilical cord to go into the other baby and which can kill the other fetuses. You are just preventing it by occluding the cord. That's all. Once you occluded the cord, the toxic substances from the dead baby cannot transfer into the abnormal intertwining circulation. Simple as that. So that is important. You go here and then you do things, because in these cases the heart takes quite a long time to stop. This is another case where you cannot do cord catching because the other fetus is normal. This is an abnormal fetus which is larger fetus. So in this case, this TTTS fetus had a cardiac abnormality. Since the cardiac abnormality was there, we wanted to kill this particular fetus, not that the normal smaller fetus. So we went inside and used a laser to coagulate the fetal abdominal aorta close to the fetal cord structures, so that again the fetus toxic substances do not cross the circulation. So we used a laser in these cases. You see here that's a hydrops, a cardiac abnormality, and after reducing this happens. This is a very rare sequence. That's a trap, which again is a complication of monochorionic twinning, twin reversed arterial perfusion sequence, where one of the fetus is larger, the other fetus is abnormal. That is absolutely no trunk, upper trunk and the cephalic portion. So here what happens, this baby actually takes all the blood from this baby. So this is the pump twin. This does not have a heart. So this is the pump twin and this becomes a recipient twin. So what do? You have to go inside this abnormal fetus and coagulate this vessel. You have to coagulate. You cannot clamp it. You have to coagulate this vessel. That is very important. If you coagulate this vessel, the cross circulation automatically happens into this particular vessel. So here is the abnormality. So here that is the, sorry, that video is not running. So here this is the abnormality, and we went inside and did a cord coagulation in this abnormal fetus, and that lead to a normal, the other fetus. This is the abnormal fetus. This is a normal fetus. So we went and coagulated that particular frequency. Again, there is a question being asked, can I use RF in that? So RF and laser both have same thing. You have to give heat so that you coagulate that particular vessel. That's all. So We have both radio frequency and RF ablation. So we use radio frequency and the laser. So you can use it accordingly whenever you want. The advantage of radio frequency ablation is you have a you go inside and that can flower. Actually, that particular needle can flower and can cover a larger area of coagulation in these cases. So this is again another case of fetal tracheal occlusion in cases of diaphragmatic hernias, which you can do. I have not done this procedure personally because this is quite not affordable in our part. I've seen one case being done when I was in UK. So this was a case where you could see here the baby is paralyzed, baby is intubated through the scope, and then a balloon is deployed inside the trachea in order to expand the lung, so that in order to expand the lung to put the diaphragmatic hernia away, so that the diaphragmatic hernia does not compress the fetal lung. See, the problem in diaphragmatic hernia is not the hernia. It is because it is causing chronic compression on the fetal lung that can lead to fetal lung immaturity, that will lead to the postnatal complications. Since the lung is compressed, it will not be able to produce the type 2 pneumatocytes. Since type 2 pneumatocytes are not produced, the lung alveolar sacs does not develop. Because for the lung to develop, the baby has to constantly swallow in amniotic fluid and then get it out. When this does not happen because of chronic compression, that leads to fetal lung maturity. So what they do is they go and plug the trachea so that the lung is kept at the expanded state always. So the lung maturity happens. This is the general treatment. Final thing is an amniotic band. So amniotic band, all amniotic bands need not be treated. When you have an amniotic band which can encircle the head, or say when it can encircle the hand or a leg, where you can just go and do a laser. Just cut the amniotic band with a laser. So these are the common interventions that can be done in the basic and the advanced till now. So these are basic things. Now even genetic impact is quite high. Genetic research has been done in a very larger ways, and recently a lot of genetic syndromes has been treated by giving a transfusion of certain genetic medicines into the fetus has been tried. These are all in the startup stage. Let's say pluripotent stem cells has been tried, and so much things are being tried and given. So the important point is to know the fetal ethical issues. As I already told you, as doctors, we can tell the patient the options, but we are going to transgress the maternal tissues or a maternal body to enter into the fetus to treat. So it absolutely is just the wish and will of the mother and the father whether they want to take up the procedure or not. So tell them all the negative points. This is very important. We generally avoid telling a negative point, thinking patient will not come to you. Patient may go out. That's not true. When you're very confident saying we have done so many cases, yes, this is a complication that can happen. Are you ready for the complications? Few patients do turn out, but many patients do be there, and that gives you a very safe practice. So as doctors, we need to know the future is about the stem cell therapy and fetal surgeries. There's one thing called as exit procedure. You should know the word exit procedure as doctors and radiologists. It is nothing but there are two things. One is fetal surgery, where you open the maternal abdomen, take out the baby, do the let's say neuron. Let's say if there is a spinal dysraphism, close the open spinal dysraphism, allow the baby to go in back and continue the pregnancy. That is one that's called fetal surgeries. The other one is exit procedure. Exit procedure is done in a few cases. Let's say when you have a large mass sitting in the base of the tongue, or let's say you have a congenital diaphragmatic hernia, or you have a large ranula sitting, or there is exhaust. See, all these things, what happens is before cutting the cord, the baby is intubated, and the baby's respiratory system is taken into control by the surgeon and the anesthetist. After that, it is cut, and the baby's emergency treatment, whatever is has to be done, it can be done, and then the baby is taken. So there are a lot of things which can undergo exit. The word exit procedure is the word I want to put it into your minds. So, as doctors and radiologists, as an interventional fetal radiologist, you have to step into the clinical role by talking to the patient, by telling them the possibilities. We are not heroes. Remember, we have so many abnormalities. We are treating only 2% of these cases. What you should do, you should know how to screen and how to screen early. Number two, you need to have an adequate knowledge on what you're doing. Number three, gain expertise. How do I gain expertise? Do more cases, do more ultrasounds, do more cases, do Dopplers. Whether asked for or not, do Dopplers. Whether asked for or not, do a fetal echo in all these cases. Spend 5 more minutes in every case, which can which can reap so much benefits to you in the future. Treat only the possible. You should know when to avoid doing the procedure. You should know when not to do, and try to prevent complications so that you get a very healthy, neurologically intact, survivable baby into this tough world. Thank you.
Thank you, sir, for the extensive and beautiful